talk will be by Dr. Johan Blanckaert. And Dr. Blanckaert is also using Trinova with flux technique, and he will tell us his first result.
Thank you. So I'm going to talk, I'm a surgeon, and so I'm going to translate all the information the physicists are giving to me into useful information for surgeon and patient. These are my financial disclosures. So first of all, I traveled recently to the southern point of South Africa, and I had the chance to see the early Fresnel type of a lighthouse, and really that struck me that you can see that there's a nice Fresnel. So the Fresnel design is really an old design, and these are sharp edges of the diffractive rings, and we have discussed already the light loss it causes. You can see it here because this is illuminated from behind. This is the first Fresnel lens which was incorporated in the lighthouse, and you can see there are darker areas. That's the light which is going to another place. So if we go to the US Air Force target tests, then it's really important that you have a difference between the Fresnel types and the new one. In photopic, we have all seen that those far, intermediate, and near vision US Air Force targets are quite good. That's what we had before. And in mesopic conditions, it gets worse for the intermediate and the near, but somehow the far vision stays the same. But we have complaints with Fresnel types of trifocals, like waxy vision, blurred vision at near, blurred vision at intermediate. So we have some concerns. And then, when they presented the new trifocal IOL, they showed MTF curves, and it's sometimes difficult for a surgeon and more difficult for a patient to understand precisely what's the difference between the different lenses, because the differences are not so well depicted on the MTF curves. But if you look at the light distribution in photopic condition, then you can see that it's really a horizontal type of presentation according to the opening of your pupil. So that was the question we had some time ago. Pupil independence it is. And in mesopic conditions, you can see that light goes a little bit more to the far image, and the intermediate and the near switched. So you have more light going to the near, and it's still pupil independent. So my choice in choosing a multifocal IOL, we have a lot. We have the obvious ones: chromatic aberration control, retinal photoprotection, the square edge for the PCO. But really, I like the fact that light transmission and the mesopic conditions acceptable vision in far and near focus, that's the really key point which is important for my patients. And lastly, since 2015, we have the concept of the enhanced depth of vision, the ADOF principle. So it's good to know that the light transmission, as we had seen in earlier presentations, is the highest of the trifocal competition. And if you look at US Air Force target tests, then you can translate the highest transmission also to the image quality. And the Fresnel types of trifocals are clearly inferior to the image quality in the new sinusoidal type of trifocal. This is in photopic conditions, but what strikes me the most is the mesopic conditions. The far focus is still a much better image quality than what the Fresnel types of trifocals can give you. So this is really important for your patient, that you can tell him that the image quality for far is as good as what you can promise with monofocals. which in the Fresnel types of trifocals was not the case. So the surgery is the Iol calculation. We have the A constant list on the eolcon.org. I use the Lenstar biometer with 3 formulas, the Hill RBF, Barrett Universal, and the Olsen Iol calculation for the calculation of my Iol power. And the astigmatism control is by the Verion digital marker. So I use the femtolaser-assisted cataract surgery plus the Verion digital marker. These capsulorhexis is made at 4.8 millimeters, and I have a central cylinder and 6 divisions of my nucleus. So here you can see that it's quite an easy centering IOL. You can see with the visual axis that it's nicely centering on the visual axis. So the preparation of the IOL, it's easy to get it out of your container which you get. And then everybody has his own tricks, but to put it into the cartridge, I use a little trick to be sure that it's bent downwards, and that's by grasping the IOL and the cartridge, and now you can close it and hear the click before loading it to the injector. And this is the same type of image. You clean the viscoelastic from behind the IOL, and then you see that it's good and easy centration. So what about the latest development, which is the seamless continuous vision? I have to say I was skeptical about it when they first presented it to me, because I said, yeah, but we still have physiological limitations of our IOL. So, and then the enhanced depth of vision became really something which I appreciated by doing some tests with my patients. And this is a patient, and you could see, I can start again, you can see that he's coming from the normal reading distance. He reads the Snellen 2 line, and I ask him specifically to go further on until it's non-clear, until he cannot read anymore. And the most of my patients are saying that their arms are too short and that they can see quite up to 80 centimeters of intermediate. So the seamless continuous vision is proof of concept and has been proven in patients. I did 25 bilateral patients, and my uncorrected visual acuity was 10/10 and Snellen 2 for the near vision. So my conclusion is excellent far vision and also low mesopic far vision, which is in relation with the high light transmission. You have the continuous vision near from 38 to 80 centimeter, minimal complaints of halo, and spectacle independence, which is very high, more than 90%. So I have great satisfaction even in mesopic conditions of my patients, and therefore doctor and staff satisfaction, which is kind of high. And now I know why one of my patients said to me that the grass is greener after surgery. I just heard it with the colors. Thank you for the explanation. Thank you.
Thank you. I think we have some additional time for discussion. So after your large experience, are there patients for you that are not ideal candidates for this lens? So this is a lens nearly for everyone.
At the beginning, I focused on the hyperopic patients, like everybody does with the trifocals. But now I see, and I was happy to learn that other surgeons also experience that you can go to the myopic side of your patient population. And that's something which was never seen before. If you look now at your myopic patients, you can see that the expectation is very high. And
okay, so my patient is, most of my patient is very high myopias. And I implanted a zero diopter also for these lenses. That's a good result. Patient satisfaction is very good.
So in your opinion, we can target highly myopic eyes as well with this lens?
Yeah, high myopia patient and also myopia, high myopia patient and also mild myopia and all kind of patient we can try it.
Great, thank you. Your opinion, do you share the same opinion, Ruth and Eva?
Well, I guess I am a little bit more conservative than that. High myopes are different eyes, but then I don't come from the Far East. You have much more experience with high myopia than I have. In a refractive lens exchange, I always prefer a slightly hyperopic patient. In cataract patients, I don't think it matters what their previous refraction was. They have bad vision, they need a solution, and if they want multifocal, I think that's the way to go. I hope that very soon we'll make the mind switch that we offer multifocal IOLs to all our patients, and we will only have a few excluded because they have a specific ocular problem not to do so. And I think we're on the step on that road.
This is the future. Eva and then the floor.
I agree with you because really the rejected from the qualification is really very short, only with the problem with cornea, because we don't know really if in the shape is okay for the patients with a problem with cornea, but until now we don't implant it with the patients with some corneal problem or after refractive procedure.
We can accept one question from the floor, and then I think they will throw us out of this room. Please go ahead.
I would like to ask you, all panel, one general question. How should we categorize this lens as trifocal, as EDOF, or both of them? If we accept combined type,
That's a good question.
Obtained effect comes from trifocal side or EDOF side. Can you say something?
A good question, because innovations are difficult to categorize. What's your opinion? Starting from Ruth and then all our speakers.
I think this is basically a trifocal IOL with a very good continued line of vision from distance to near. So if you have a good continued vision, you could use the marketing term of extended depth of focus. However, this is a very new innovation, and the data are not out yet there of how completely the optics were done because of patenting issues. But in my opinion, also, if you look at the MTF, you have a distance focus, an intermediate and a near, and in between, excellent vision. Okay?
Quickly.
Yeah, I agree with her.
Okay.
Yeah, that's all.
Yeah, I agree.
Yeah, I would also like to add a little bit on this question, because this is really a difficult one, because you see these sinusoidal curves and you don't really see, you know, the shapes that would produce trifocality. However, that's the combination of trifocal and EDOF lens, actually, and it really does show characteristic of both, and this was nicely shown by Dr. Lapid-Kozak, that it has the lowest stray light of them all. So that is going into more to EDOF lens. Perhaps that's slightly longer distance for reading than we are used to classic trifocals, but on actually benefit of less stray light and less halos.
Thank you. So guys, I think it's time to finish this interesting session. Thank you, Marco. And thank all my speakers today. Continue to enjoy the meeting. This is ESCRS, the most exciting meeting on ophthalmology in the world.